Welcome to PAMED Talks, a podcast brought to you by the Pennsylvania Medical Society. I'm Julie Heaney of the Foundation of the Pennsylvania Medical Society, and today we're joined by Dr. Kristen Sandel, practicing emergency physician, as well as medical director of the emergency department and president of the medical staff at WellSpan Ephrata. Her name likely sounds familiar, as she also served as the 174th president of the Pennsylvania Medical Society, and she currently serves on the Foundation's Board of Trustees. In light of the upcoming Emergency Medicine Day on May 27th, Dr. Sandel is here to speak more about her position as a physician reviewer for the Foundation's LifeGuard Program, a clinical competency program that provides individualized assessments and remediation plans for physicians nationwide. Thank you for joining us, Dr. Sandel.
Thank you for having me. I appreciate it.
So, LifeGuard has a 6-month program to assist emergency medicine physicians with a pathway to return to board eligibility with the American Board of Emergency Medicine, or ABEM. It's a program that has been approved by the American Board of Emergency Medicine, which involves an assessment phase, an individual learning phase, a clinical phase, and then a final report regarding the physician's performance is provided to the physicians and ABEM. Can you explain a little more about this program from your perspective and your involvement in it?
Sure. So a few years ago, I was approached by Lifeguard and Heather Wilson to assist with a pilot program involving emergency medicine and taking a look at how we can reintegrate some of the emergency medicine physicians who had been out of practice for a number of years, and get them back into practicing safe, quality care in the emergency department. And from that, um, from the pilot, we introduced that to ABEM, which is the American Board of Emergency Medicine, and they were very interested in what we were doing, and they decided to create a partnership with us to not only help people get back into their career in emergency medicine, but also to assist emergency physicians who had difficulty passing the initial certifying exam, and then moving forward to ensure that they are passing the qualification exam to ensure that they can practice emergency medicine in their respective organizations.
Can you share a little bit about your background in emergency medicine and your role as a reviewer?
Sure. So I've been an emergency medicine physician for now 20 years as a attending emergency physician. I initially worked at a level 1 trauma center for a number of years. I was instrumental in teaching the medical students. I was medical student clerkship director there, as well as an off-service resident director. And then we actually implemented an emergency medicine physician residency program in that hospital as well. So I have a long background in teaching emergency physicians and medical students, and also physicians in other specialties. And so I was able to leverage that into what I'm doing now in the LifeGuard program.
From your perspective, how has the practice of emergency medicine changed over the past 5 to 10 years?
Oh, it's completely different. What 20, even 20 years ago when I was an emergency physician, and going back further. So I'll give you a little background on emergency medicine. So emergency medicine is one of the newer specialties in medicine. We only had residencies in the early 70s. We became a certified specialty in the late 70s, early 80s. And so, even though that was 45 years ago, that's still new when we talk about, careers in medicine. And so, back in the day, people would go to the emergency department if they were having a heart attack, or if they were in a bad car accident, or if they fell, or if they broke a bone, or they had a laceration. And that's not the case today. As we've evolved over the last 45 years, we recognize that we are the safety net for society. So, people that are homeless, people that have substance abuse issues, people that have behavioral health issues, people that need expedited workups. So, they go to their doctor, but they need labs, they need imaging studies, they need specialty care. Those patients are all directed to the emergency department. And along with that, we have an aging population, as you may know. And so, there's a lot of patients with dementia or with other cognitive impairments that are sent to the emergency department because of behavioral issues or because they just can't live at home anymore. And so we are, again, the safety net for that population. And so, on any given day, people ask me about the pit. I don't watch the pit. I live the pit. But I don't watch the pit. But it's not all the glamour that everybody sees on TV. A lot of it is social service issues, is family issues, or other issues that we deal with. It's not all the trauma and all the things that are glamorized on TV.
Would it be accurate to say that expectations for emergency medicine physicians are higher now than they used to be?
Oh, of course. People come into the emergency department and they want to know what's wrong with them immediately. And sometimes these symptoms have been going on for weeks or months or even years, and they've seen multiple specialists. But today is the day that they come to the emergency department and they want, they want answers. And we often say emergency physicians are a jack of all trades, but master of none. And that's what we do. We know a little bit about a lot, but we are not experts in any of the specialties, and we do rely on our consultants and our partners to assist us with diagnoses and treatment. But often we don't give patients answers, and that is not necessarily a patient satisfier when we're working.
So, getting more into your role as a physician reviewer,
Mhm.
based on your experience, where do you most commonly see knowledge gaps in practicing physicians?
Great question. I think most emergency physicians are very comfortable in the high volume situations that we're in. So whether it's trauma, cardiovascular disease, heart attacks, strokes, those types of issues, we are very knowledgeable and very comfortable. Abdominal emergencies, thoracic emergencies, where I think we see gaps in knowledge are for some of the rarer conditions. So things in hematology, immunology, some of the infectious disease. Um, Again, some of the what we call zebras, not necessarily the horses. And so when we get into those types of situations, that's where, I used to tell the residents when I'm not sure, I punt. I use a football term, and I punt to someone else to assist me. And that's not it's not a show of weakness. It's a show of strength. When you say, I'm not the person that is the expert in this field. I need to rely on some of my colleagues to assist me with these diagnoses.
How does knowledge retention change over time after residency for emergency medicine physicians?
I think there are two things. One, you really gain experience by the number of patients that you see. And I uh, I talk to my younger attending staff about this all the time in the department that I work in. The more patients you see, the more you see, the more you get comfortable in your own practice. And so as you are more experienced in your career, you've seen more patients and you've seen things and you see patterns, and you're more able to make the diagnosis and get the patient on the path to recovery. I think where as you get more experience, you do need to ensure that you keep up with the changes in emergency medicine. Again, medicine, it's sometimes it moves at a glacial pace, we say. And so some of the things don't necessarily come out, weekly or monthly or yearly. But there are changes in medicine that we need to ensure that we keep up with. And so it's important for people to go to conferences and do CME and do all of those things that keep us up to date to ensure that we're delivering the most up to date care for our patients.
How much of what you see would you say can be attributed to knowledge gaps versus decision making or cognitive errors?
Yeah, I think it depends on the physician. We all have to pass the qualifying exam, which is the first exam for the written exam for the boards. And then we do an oral examination, which was changed a little bit over the past couple of years, but we all pass that. And then we have to go on and maintain our board eligibility by ensuring that we do the continuing medical education and that we do the other portions of the ABEM requirements to ensure that we are still board certified. And so, it is important for everybody to kind of stay up to date with those things. Many of the physicians, they do very well in staying up to date. And truthfully, the medical staffs that the physicians are in, there are a lot of things that we need to do to ensure that we stay up to date. And almost every hospital has peer review and other things that we do so that we safeguard our patients to ensure that we're delivering safe care.
What makes the ABEM certification and recertification particularly challenging?
Yeah, so the initial certification is a closed book exam. You go to a testing center, you take the qualifying exam. It's a multiple choice test. It lasts for about a day. And once you pass that, then you go on to the oral boards. And again, we are changing the oral boards in ABEM this year. So instead of just doing case reviews, there's a mix of simulated case reviews, procedural component as well, where you demonstrate procedures. Ultrasound is a huge portion of emergency medicine. So now they have an ultrasound portion of the exam as well. And then also dealing with conflict. So we all know that we have an issue with workplace violence in the emergency departments as well as the hospitals and in healthcare in general. And so, how do you de-escalate those patients that are not necessarily happy with you? Um, and how do you avoid, not avoid conflict, but deal with conflict in the emergency department? And so, those are the components now of the qualifying exam. As far as the ongoing education that we do, we used to have every 10 years we would do a similar qualifying exam where we would take a multiple choice test. Now they changed that, which I think is a great change from ABEM. And so now we do questions. They are at home, it's open book, which is what we do in the emergency department. We're allowed to use anything at our disposal in the emergency department to assist in patient care. And this is how the new recertification is. And so we have to make sure we keep up with the literature, but also perform a number of tests every couple years to make sure that we are still practicing safe care and that our knowledge is up to date.
So you mentioned using anything at your disposal
Mhm.
in practice, but also you're allowed to kind of do that on the test.
Mhm.
Do you think the board exams accurately reflect real world emergency medicine practice, or they're growing to, or they're way closer than they were 45
I
years
think it's
ago?
evolving. I think it's evolving, and there are things that you do on the test that I wouldn't do in real life because it depends on what your hospital resources are. Not every hospital has every resource at their disposal, and not every hospital doesn't have every resource at their disposal. And so, it does depend where you practice. And so, you take what's in the books and you try to translate it into your practice, but you also have to keep in mind when you're taking these exams that while in practice you're doing five things at one time, on an exam you have to prioritize those one, two, three, four, five. And I think that's where people get confused because if a patient has an appendicitis, you might be calling the surgeon, giving the antibiotics, calling the OR, talking to the patient about their diagnosis all at one time. But on a test, they want you to prioritize those things.
Other than resources, where else do you see disconnects between test performance and bedside performance?
Um, most people do very well, in translating what is in the knowledge base on the test into bedside performance. I think emergency medicine as a specialty is a very people person specialty. It's public facing. You can't hide in a dark room. You can't hide in a lab. You can't hide in an office. You are with the public. And so, I think that the things that we learn on the book in the books, we can translate pretty well to the bedside. Again, depending on where you work, your patient population, what your resources are, all of those different types of things factor into how you deliver your care. But I think inherently we all, obviously strive to give the best care that we can based on our education and the patient that's put in front of us.
So, transitioning a little bit on the topic to burnout, which I know is a very popular talking point everywhere, especially with the pit, which we talked about. How do you think burnout impacts a physician's ability to learn and retain information, especially in the emergency department?
Emergency physicians have been pretty much either number one or number two as far as the specialties for burnout. And that's for a number of reasons. It's a high stakes field. It's a high reward, but also a high stress level. We are shift workers, so we work 24/7, 7 days a week, 365 days a year. We can't turn away any patient, so whatever shows up, we treat. And most of us are trained to not let that show in our faces or in our emotions when we're working in the emergency department. So a lot of us keep that internally and then we take it home. And sometimes we have good outlets of stress relief and of emotional intelligence and all of those different types of things that we learn about to ensure that we don't have difficulty with those situations. But a lot of us, take a lot of those cases to heart. We see babies die, we see babies born, we see traumatic incidents, overdoses, young people with trauma, all of those different types of things, and all of us react differently to it. And so, burnout is very high in our field because, again, many times we are the people that are telling bad news to a lot of patients and family members. Um, I was a victim of burnout. That was a platform of my presidency is talking about resilience in medicine and how we can ensure that we keep physicians continuing to practice long after they graduate residency. Emergency physicians last usually about 20 years. Maybe even less. A lot of times there's been some data for women that they get out of emergency medicine more sooner than our male counterparts, just because of some burnout and some other family things that are going on. And so it is tough and it is hard to combat, but there are things that hospitals have, EAP, employee assistance programs, and a lot of emergency medicine groups online on social media platforms that people can discuss the way they're feeling and all of those different types of things. But it's real and it's not going away. It's a little better than it was. During COVID, it was pretty high. But it is getting better. The AMA actually just released a statement about it, about burnout. And again, emergency medicine is still number one. But it is a little bit improved from where we were before. So we'll see how things go over the next couple years. But I do think that there is a lot of pressure when you're working in that emergency department, especially when you're a solo practitioner and you're working alone and you have a full department. It's a tough job, and I think until Unless you really have worked it or you've seen it, it's hard to even fathom things that you see and what you deal with.
Separate from burnout, what do you see or where do you see emergency medicine heading in the next few years, or emergency medicine education? I mean,
Sure.
in terms of like broad things or technology, AI, what do you think?
So, one of the things that we see is that a lot of our colleagues are going to some telemedicine solutions. And so we see that I think we most hospitals see it with strokes and with teleneurology. A lot of us use teleneurology to assist us with stroke care in the acute phase of that disease process. There are other telemedicine solutions as well. We use them for things like burn patients. Some people use it for dermatology, for subspecialty care. So we do see that. As far as AI, we use AI at our hospital for charting. So we have a program through our electronic medical record that some of our physicians use, and it can record the conversation with the patient's consent, and then it will give us a nice chart, and then we just have to review it and then modify it as we see fit. Um, the other AI that we see a fair amount is with our radiology colleagues. They are utilizing artificial intelligence. They have been for years, a couple years, for various radiologic conditions. Many use it for mammograms, which obviously we don't do in the ER, but mammography is one of the ones that we see. Our radiologists and many radiologists use AI for evaluating for pneumothorax, collapsed lungs, for pulmonary embolisms, for intracranial hemorrhages, all of those different types of things. And it's a great assist device. We find that sometimes it does overcall things. And we do have to, balance the use of AI with a human that actually looks at the studies and can ensure that we are, not just relying on our technology, but also relying on human eyes to actually look at the patient, look at the studies, and make an informed decision.
Based on everything we've discussed, what do you think emergency physicians really need from an assessment or prep program like LifeGuard?
Yeah, so I think that one of the things that we try to do is we try to assess where the opportunities are with the candidates. So I think most of us we all know where our strengths are, where our weaknesses are, or we think we know. But sometimes it takes, someone else from the outside looking in to say, these are the things that you may want to key on. I think that most people have the knowledge base. Sometimes it's a testing issue, where the physicians are having difficulty with just the testing, and the multiple choice, and ensuring that we do a good job as in the program to look and see how we can help the physicians with their test taking strategies. Knowing, what's in the stem of the question. Um, in general, boards do not put anything in there that's extraneous. So if there's a location, there's a specific nuance or an adjective that's used, it's usually important. And so, keying on those things so that when you're between two answers or three answers, that you look really closely at those questions and can tease out which one is the most correct answer. And so we see that a lot. Um, and so again, all emergency medicine programs are certified, so they all have, certification through the ACGME, but just ensuring that we are looking at the way people are taking tests and looking at their background of, what they had trouble with in the past and how can we get them to where we feel that they are going to be successful by looking at the past, you know, um, doing some education in the present and then getting to the future.
If you could give one piece of advice to an emergency physician preparing for their boards, what would it be?
Take it early. So, a lot of the candidates that we have in the lifeguard program delayed their boards due to various issues, whether it's life circumstances, job circumstances, just didn't feel comfortable taking it right out of the gate. I find that people who delayed taking the boards are ones that end up coming to us. So, um, if you have a 3-year program residency or a 4-year program residency, and you're taking the boards in that late October, early November, take the boards then, because that's when you're the most prepared. After you did that residency, you've had all the lectures, you've had all the the education from your programs. That's the, I think, easiest way to pass. I find that when people delay, if they delay a year or 2 or 3, because you can take the boards up to 5 years after you finish residency. And so when people end up delaying, I think that's when they lose that um, book education, and they start getting the clinical education that we talked about earlier. And so there are things that you do in the emergency department that are all simultaneous that is not what's on the exam. And so I think that's the most important thing, is just taking it early.
Okay, take it early. Do not delay. What would you say to, and this is my last question, what would you say to an individual who might be hesitant to reach out to the lifeguard program?
Oh, I mean, everybody in the lifeguard program is so nice. I know all of the other instructors. Most of them were either residency directors or chairs of their department, or they're wellness gurus, or they're neuropsychologists who help. And so, it's a very friendly, benign program. This is not, we always talk about the carrot and the stick. This is the carrot. There is no stick. Um, we're here to help. We're not here to make you feel badly about yourself or make you feel badly about, your past successes or failures or whatever happened in the past. The most important thing is, getting you through. And so if that means, I used to do kind of all of the program when I first started, because I was the pilot physician who did it. Now I usually do more of the testing, the Rosh review, kind of going over things. But, when I meet with the candidates, I talk to them about their life. What's going on? How was your shift? Give me a good case. What happened in your last shift that was interesting? I'll tell them what happened in my last shift that was interesting, or the stupid stuff that I did, when I was a resident or a young attending, or even yesterday. And so I think, everybody's pretty laid back, and we go over the tests and we figure out how can we help you. And if that means, taking 3 or 4 or 5, mini quizzes and going over those and, studying, or if that means, you just had a bad day when you were taking the test and you waited too long, and now you have to go through the program. Sometimes I don't have to spend a lot of time with people because they're ready. So we gauge that both by the program, instructors, as well as the participants, and we work with them to ensure that we're both comfortable with where they are, and we're comfortable with hopefully getting them through the boards.
Thanks. Well, for those who are listening, if you're interested in finding out more about the ABEM certification program or our lifeguard program, you can visit lifeguardprogram.com. Thank you so much for joining us today, Dr. Sandel, and happy early Emergency Physicians Day.
Thank you. I'll be sure to celebrate.
Okay, good. Well, we appreciate all the work you do. Thanks.
Thank you.